Thank you. Well, good morning again. I know we've not reached afternoon yet. It's a pleasure being here. This is the fourth talk I'm giving this convention, this conference, so they really put me to work this visit, but it has been a pleasure. Since we have a couple of minutes, I've put this picture in many of my talks. I'm going to talk a little bit to this picture. So this is Henry Ford. This is main Henry Ford Hospital. And the Henry Ford Hospital was built by Henry Ford himself, so the guy who owns the Ford Motor Company about 100 plus years ago. And the history behind it is that at that time, what he really wanted to do, he wanted to build a hospital in the city that's different from what's being delivered as far as care. But he's in the industry, he's in manufacturing, he's into car industry, and he had no idea what to do. So he went to the Mayo brothers at that time, and the Mayo Clinic was already up and working for about 15, 20 years. So he told them, what do you really help me? I need some help, I'm not in the medical field. And they told him, well, what you need to do is go and get some good physicians, hire them, put them as fully employed physicians into the hospital, and this is how you are going to run your hospital. And this is at a time where healthcare in the United States was mostly into private practice, a lot of family practice, surgeons that will kind of see patients in their clinics and kind of bring them to the hospital. So the whole concept of employed physicians did not exist in hospitals at that time, except in places like the Mayo Clinic. So he went and kind of went to Hopkins, tried to kind of get few people, and he ended up getting the first few chairmen of multiple departments were from Hopkins, in fact. McClure in surgery, Sladen in medicine, Pratt. So for those of you who use Pratt dilators, Dr. Pratt was one of the first chairs of GYN in the hospital of Henry Ford Hospital. And now we are 102 years ago in 2015, we celebrated our centennial for the hospital. So this building that you are seeing is 100-year-old, not the tall one, but this is 100-year-old, and it's really interesting. I have in one of my offices, I have a picture of how that building looked about 100 years ago, and it did not look that much different. The kind of all the grass in front of it and the landscaping is different, but the building is not different. So for those of you who are in Detroit at any time or visiting the Midwest, please, you have an open invitation to kind of to kind of visit with us. My talk today is on gestational trophoblastic disease. I really wanted to kind of share with you some tips, and I know there are many people in this audience, gynecologists as well as gynecologic cancer specialists who are very well versed in this topic. So it is more of a quick review and some of the tips. And this is from a publication by John Lorraine, who is at Northwestern University, and they have a Center for Gestational Trophoblastic Disease there. And as you know, gestational trophoblastic disease is really a spectrum that starts with hydatidiform mole and ends up with choriocarcinoma. PSTT, which is placental cytotrophoblastic tumor, is an additional entity that's a little bit different from that spectrum. What is most important with gestational trophoblastic disease, which is similar to what we have seen with ovarian germ cell tumor, that we took a disease that was really deadly in the past to a disease which is highly curable at this point. So in the past, the mortality rate with invasive mole used to be 15%, with choriocarcinoma is 100%. Today's success rate of treatment is over 90%. So even in people who have choriocarcinoma with metastasis to the brain, there is still high cure rate in the 60 to 70% and sometimes 80%. So it is very important to recognize that, but it's also important to recognize in order to achieve these high cure rates, you need to do the right treatments and make sure that you diagnose the patients in a timely fashion. This is a slide about the epidemiology of gestational trophoblastic disease, and this is really not meant for each of you to kind of remember the numbers, but just to give you an idea that this disease varies a lot depending on where you are and what area of the world you are in. And there are different kind of incidence rates that vary from place to place. I can tell you when I was in Saudi for 3 years, I've probably seen more gestational trophoblastic disease than I've seen in 15, 20 years of practice in the United States. Not only I've seen more gestational trophoblastic disease, but I've probably managed every single complication and metastasis of gestational trophoblastic disease. So obviously there are areas here of the Middle East where we have higher incidence and we see more complication than we see in other places of the world. Risk factors for gestation trophoblastic disease, these are well known. So early age and advanced age at pregnancy, prior molar pregnancy is definitely associated with that. And recently, as we started understanding more the genetic of diseases, a missense mutation in NLRP7, which is on the chromosome 19, long arm, is one of the predisposing factors for gestation trophoblastic disease. As far as choriocarcinoma, the most common and highest risk for choriocarcinoma is a prior history of molar pregnancy. And this gives you, if you are to, at the present time, so we looked before at the risk, and we said the risk is about 1 to 2 per 1,000 pregnancy. However, when you start having prior history of gestation trophoblastic disease, that risk increases significantly. So if you have a patient at the present time who has had a prior molar pregnancy and comes in with a subsequent pregnancy, and she asks you, what is my risk of having another molar pregnancy? It's about 10-fold increase at the present time. If the patient has had now two prior molar pregnancies, her risk increases significantly. So it's about now anything between 15 and 25%. So we are looking at a significant risk at the present time. And if a patient has had 3 prior molar pregnancy, it is almost, you have almost certainty that you have a very high risk that you are dealing with a gestation trophoblastic disease. The most common problem with gestation trophoblastic disease used to be vaginal bleeding and enlarged uterus. However, since at the present time, with the advances of ultrasonography and with the fact that many of the women that you are taking care of are coming to you at an earlier gestation age to be scanned and to have their pregnancy test done, these things are not probably as common as we've seen before. So it is much more common at the present time, at least in the United States, to make a diagnosis of gestation trophoblastic disease based on an ultrasound image and a beta-HCG level rather than presenting with an enlarged uterus and vaginal bleeding. These still occur, but they are not as common as before. It is also very uncommon at the present time for people to present with things like preeclampsia, again because of the earlier diagnosis that we are seeing these patients at. This is an ultrasound picture. It's a little bit fuzzy because of, the resolution is not the best from where I got it from. But essentially when you are looking at gestation trophoblastic disease, you are looking at absence of gestation sac, you are looking at these vesicles and multiple large vesicles that are there. You have abundance of tissue that it is in the uterus. You don't see amniotic fluid. And sometimes you can have theca lutein cysts, which can kind of probably point you in that direction. So if you have a patient, elevated beta-HCG, no gestation sac, these vesicles, and you have theca lutein cysts, this is a very high kind of concern for what you are looking at. How do you diagnose gestation trophoblastic disease? It is essentially a serum and histologic diagnosis. First, the serum diagnosis is your HCG. So we know that HCG has 2 components to it, the alpha subunit and the beta subunit. The alpha subunit of HCG is something that overlaps with LH, FSH, and TSH. So it is not specific enough. This is where when we are looking at HCG, we want to look at beta HCG to make that diagnosis. And it is the most sensitive and specific marker for gestation trophoblastic disease. And the HCG, the beta HCG, is produced by the syncytial trophoblast in normal pregnancy. However, in molar gestation and GTN, it can be also produced by the cytotrophoblast. People say, well, can we use the level of beta HCG to kind of determine for us whether we are dealing with a normal pregnancy or a gestation trophoblastic disease? And as you see here, this is a very nice graph on the right hand of the slide that shows you that there is significant overlap between normal levels of normal pregnancy and complete mole. So when you are looking at a normal pregnancy, you have 50 to 100,000, can be higher in multiple pregnancies. When you are looking at complete mole, it can be 50 to 200,000. So you are not really that far off with that. So it just tells you if you have an elevated beta HCG, it might point you, but it is not a definite diagnosis. And on the other hand, if you have a normal beta HCG, you cannot determine for certainty that this is not a gestation trophoblastic disease that you are looking at. When you are looking at a partial mole, as you see here, the beta HCG levels tend to be lower, and as such, you completely lose your discriminatory kind of benchmark for them. An important entity is something called phantom beta HCG. So there are times where you kind of get a patient has an elevated beta HCG, you don't have a pregnancy, you do an ultrasound, you do scanning, you do a biopsy or you do a curettage, there is nothing there and you are at a loss. And this is a well-known entity at the present time. And the phantom beta HCG is related to a fact that you have some proteolytic enzymes that lead to degradation of certain proteins that interfere with the human anti-mouse antibodies. It's a heterophile antibody. So what happens is that you have essentially a false elevation of the beta HCG that you get on serum testing. The good thing about it is that that protein is not, once you get it in the urine, the testing in the urine is totally different, and it does not pick up that protein as a positive protein. So usually these patients with phantom beta HCG, they will have an elevated beta serum HCG, but they have a negative urine pregnancy test. And if you repeat it a couple of times, a lot of times, and you kind of find out that this is what you're dealing with, you are definitely dealing with the phantom beta HCGs. There are certain labs in the States where you can kind of do that testing for beta HCG and determine whether you are looking for a false positive or not. I don't know whether they exist in labs here, but an easy test to do is do the urine pregnancy test. If it's negative in the presence of an elevated beta HCG, then this is what you are dealing with. Another entity that is important to remember is an entity called quiescent GTD, gestation trophoblastic disease. And this is an entity where you usually have well-differentiated syncytial trophoblasts that are sitting probably someplace in the uterus and are causing low levels of beta HCG. And you repeat it, and these levels are not increasing. You do testing, and there is nothing in these patients that you can pick up. There is nothing that you can detect. You do an MRI, you do an ultrasound, and these are microscopic cells. And usually most of these patients usually do not have any problem. However, about 1 in 4 of these patients with a quiescent GTD, all of a sudden after a period of plateauing of the beta HCG, you start seeing a lift up of the beta HCG. And in this situation, you can test for something called hyperglycosylated beta HCG, so a specific test. Because once you start seeing a pickup in your beta HCG level and you test for that hyperglycosylated HCG, then you might be dealing with a re-emergence of gestational trophoblastic disease. So in these patients who have quiescent GTD, you can watch them for some period of time, check their beta HCG level after a negative workup, and we'll talk about the negative workup, what does it mean, how do we do a workup for gestational trophoblastic disease. And then what we can do after that in these patients, if we start seeing a rise in the level, we can do another workup and decide how to treat them. So in a patient who comes to you at the present time and you suspect that you are dealing with a molar pregnancy, you do a ultrasound, you do a beta HCG, you confirm the diagnosis of a molar pregnancy. What are your next steps? First and foremost is to do a history and physical exam. You want to rule out other paraneoplastic syndromes that are related to the high level of beta HCG or the high level or the high number of trophoblastic cells and trophoblastic tissue that you have. So you want to make sure that the patient have no hyperthyroidism problem, preeclampsia, and definitely anemia. And these are the blood tests that you will order in these things. And in these patients, all what you need to do is check a chest X-ray. So when you have a molar pregnancy, you don't need to go on an ultrasound. The first thing for you is not to go and do a complete workup with CAT scans and things of the sort. Just a simple chest X-ray with blood working are the important first steps to do. How to manage these patients with molar pregnancy? Suction DNC is really the primary treatment of these patients. And what you want to make sure is you empty the uterus, prevent hemorrhage, prevent perforation at that time, and make sure that you are following up the patients afterwards. So as you see here, it is recommended that you start an oxytocin infusion before you start the suction, dilatation, and curettage. You dilate the cervix so that you get the bigger size cannula that you can get into the cervix. You do a quick suctions going in and out. Some people will recommend doing a gentle sharp curettage at the end, and what I will emphasize gentle because you don't want to develop significant scarring and synecdoche in these young patients. And uterine massage to kind of let the uterus kind of shrink down. Is there a role for hysterectomy in the primary management of gestation in molar pregnancy? So we are talking now about molar pregnancy. We've not evolved into the other forms of gestation trophoblastic neoplasia. If the patient does not desire any future fertility and she wants to have a hysterectomy, then a hysterectomy is an acceptable option as the primary treatment of molar pregnancy. It's definitely not the first thing that comes to anybody's mind because it's definitely more complicated than doing a suction curettage, but it is something that is definitely acceptable. How do you follow up these patients who have molar pregnancy? So once you've done initially the suction, dilatation, and curettage, then you follow up your beta HCG until you have normal beta HCG on for 3 consecutive weeks. And then after that, you go up and you follow up every month until normal for 6 consecutive months. There is more and more data at the present time that probably in people who have partial moles, you don't have to wait the 6 months. 3 months is probably a reasonable time to wait. And some people even in complete moles at the present time, they kind of make that recommendation that going to 3 months is not unreasonable. We continue with complete moles to wait for 6 months, with partial moles to use the 3-month kind of limit. You have to remember the average time to normalization of the beta HCG is about 99 days. As we said, we gave the half time of beta HCG before. It's a short half time, day and a half or so. So usually most of the patients will normalize that beta HCG within 100 days if they are a complete mole. With partial mole, that period is a little bit shorter because of the fact that you are starting with a lower beta HCG to start with, and you are starting with a smaller load of gestational tissue. So this is why the times of normalization are a little bit different. Contraception is usually recommended in these patients, and the reason you want to do contraception is to try to avoid a subsequent pregnancy that is going to mask for you a potential progression from a complete molar pregnancy, complete mole or molar pregnancy into gestation trophoblastic neoplasia. Because if somebody gets pregnant within that period of time and their beta HCG starts rising, now you are confused. Am I dealing with just a normal pregnancy, or am I dealing with this molar pregnancy transforming into a gestational trophoblastic neoplasia? And you have this dilemma and you don't know what to do at that point. What is also important is that in people who have had prior molar pregnancy, examining the placenta as well as monitoring the HCG postpartum is important, because these women, remember, who had a molar pregnancy and who have had a normal pregnancy after the molar pregnancy have had increased risk of having choriocarcinoma of the placenta itself. So there are few case reports and case series. We've published one about 20 years ago when there were a number of cases of patients who've had prior molar pregnancy, had a normal pregnancy, and on the placenta they had a site of choriocarcinoma. So it's important to do that. There is also, we know that people who have had a prior molar pregnancy and then subsequent normal pregnancy have increased risk of developing gestational trophoblastic disease, meaning something that might necessitate chemotherapy and/or more aggressive treatment. So we have molar pregnancy, we did an evacuation, we followed up the patient. How do we make the diagnosis of gestational trophoblastic neoplasia? We said, as we mentioned, gestational trophoblastic neoplasia is a spectrum, starting with molar pregnancy, where you can evacuate and cure the patient, but there are patients who, despite evacuation, develop a neoplastic disease, develop a malignancy, if you're willing to call it as such. And these are some of the criteria that have been used and are mostly used, in fact, internationally to make a diagnosis of gestational trophoblastic neoplasia. These will include plateauing of HCG, a decline less than 10% over at least 4 values over 3 weeks. So remember, we said we measured usually beta HCG every week, but if we get into a situation where the beta HCG starts plateauing or increasing, we want to repeat it more frequently. So this is, in a matter of 3 weeks, you can repeat 4 values, and if you have less than 10% decline, this means you are dealing with a problem where the suction DNC has not helped your problem, and you might be dealing with a totally different problem. If you have a rise of your HCG, persistence over 6 months after molar evacuations. So remember, we said on the average, complete molar pregnancies normalize the beta HCG level within 99 days. So 6 months, you are looking now at 180 days. So if somebody beta HCG level continue to be positive after 180 days, this is very, very concerning. There is some data at the present time to show that if the beta HCG, if you started with a very high beta HCG and is still declining at 6 months, you can watch a little bit longer. but it is again, because of the half-life of beta-HCG, a presence of an abnormal beta-HCG after 6 months should be raise a flag for you. And obviously, if you have a histologic diagnosis of choriocarcinoma, so if you are doing a suction DNC and you are not finding only a complete mole or partial mole, but you have now a choriocarcinoma, then this is gestation trophoblastic neoplasia by definition. You don't need to wait for all of these follow-ups. This is a patient who needs treatment from the get-go immediately after your suction DNC. These are risk factors that you can find in every single textbook probably, and this will include your pre-evacuation levels of beta-HCG over 100,000, large fecal luteal cysts, significant uterine enlargement, age, as we mentioned, and if you've done a karyotype, you have aneuploidy models, aneuploid mole, and increased risk for, again, lower regression. If you are to look at the risks of developing persistent gestation trophoblastic disease, so we look at molar pregnancy. We mentioned the factors before in the prior slides, these multiple factors, and this will place a patient in a low risk or high risk category. So if you have somebody who has a low risk molar pregnancy when you first evacuate them, and you want to counsel them, you tell them your risk of developing a non-metastatic gestation trophoblastic neoplasia is about 3.4%. So it's less than 5%. And the risk of that patient having a metastatic gestation trophoblastic neoplasia is less than 1%, so quite low. Versus if you take somebody who has one of these high risk factors we talk about, then the risk of developing gestation trophoblastic neoplasia is 30%. So almost 1 in 3 women who have these high risk factors will have gestation trophoblastic neoplasia. So this is important to keep in mind. There's a debate in the literature whether these patients who have high-risk molar pregnancy, so you did an evacuation, it's a molar pregnancy, it's a complete mole, and they have these risk factors about them, there is some kind of discussion, should these patients get some kind of prophylactic chemotherapy? So should you give them some treatment to prevent the risk of developing gestation trophoblastic neoplasia? And the discussion and the opinions are divided, because on one hand, you can say, well, I'm trying to protect 1 out of 3 women. On the other hand, you say, well, I might be giving 2 out of 3 women unnecessary chemotherapy because 2 out of 3 of them will not develop gestation trophoblastic neoplasia. So it is really a balance that you have to kind of take into consideration when you are making that decision. And there is no right or wrong answer in the literature with respect to that. So we have complete mole. Beta-HCG is not going down. We are concerned now we have gestation trophoblastic neoplasia. What do we do for this patient? Obviously, we examine them. We do blood testing on them. Now we do chest X-ray, or some people recommend, in fact, CAT scan of the chest because it has a higher sensitivity to pick up lung lesions. We do a CT of abdomen and pelvis. And if there are symptoms, or if the CT of the chest or CT of the liver are positive for metastasis, then you need to evaluate the brain because there is a high risk for brain metastasis in these patients. So once at the present time we've made the diagnosis that we are beyond complete mole, that this complete mole we've evacuated but the beta-HCG is not going down, now we need to have a more advanced workup to make sure that we don't have metastasis in these patients. Once you do this evaluation, then you can stage the disease. And there are 2 kinds of staging. One that's the International Federation of Obstetrics and Gynecology staging, and the other one is the WHO score, risk scoring. And I can tell you that in the majority of the institutions in the United States and a lot of places in the world, we rely more on the WHO risk scoring than on the FIGO staging. So the risk scoring tends to be more sensitive and gives you a better prognostic prediction of how these patients are than the FIGO staging. So usually we kind of look at this as our guidance to what are the next steps of managing these patients. If the patient has a WHO risk scoring of less than 7, these are considered to be low-risk patients. And if a patient has a risk score, WHO risk score, of 7 or more, these are considered to be high-risk patients. And by stratifying patients as such, we make a decision which way to go. Are we going to go with single-agent chemotherapy, or are we going to go with multiple agent chemotherapy combination, and how we are going to manage these. For low risk gestation trophoblastic neoplasia, so those with a WHO score of less than 7, there are multiple options that we have at the present time in treating them. One of them is using single agent chemotherapy. Both single agent methotrexate as well as single agent actinomycin D have been shown to be effective in that setting. Actinomycin D tend to have a little bit of a higher response rate and cure rate than methotrexate, however has a higher toxicity profile with more toxic drugs. There are also studies that have looked at sequencing methotrexate and actinomycin D in these low-risk patients. A recent study by GOG/NRG in the United States looked at repeat curettage as a potential treatment for patients with gestation trophoblastic neoplasia. So these are patients who were evacuated, had a mortar pregnancy, persistent beta HCG elevation, negative workup, and they subjected these patients to repeat curettage. And what they found is in about 40% of these patients, by repeating a curettage, sucking curettage, they were able to kind of get them to a normalization of the beta HCG without subsequent chemotherapy. So this is something that in the past we were very reluctant to do, but now we have data to support us that in a patient that has that problem, especially if you have an abdominal ultrasound, doing a repeat suction curettage is not a crazy idea. It's a very rational, supported by data, and this was a prospective study. So this was well planned, well set, so statistically it is really valid in its response. What about hysterectomy in these patients? Well, similar to when we talked about complete mole, but now it is beyond the complete mole because now you've evacuated the uterus, and if indeed in this patient you do have persistence of gestation trophoblastic disease, you do a complete workup and the workup is negative for metastasis, and the patient does not desire future fertility, a hysterectomy is definitely an option in these patients. Survival rate of patients with low-risk gestation trophoblastic disease is over 100%. In the high-risk population, you usually go to combination chemotherapy. The most common one used is the EMACO regimen, and we are not going to go into that because really it is once you get to that point, you are using now an expert who uses these on a regular basis, and you will not be doing it yourself, or at least both of you. So talking about hysterectomy, what are the advantages of hysterectomy in that low-risk group? Because we said it is definitely a consideration. Hysterectomy will shorten the duration of the chemotherapy. So the idea behind it is that you have some disease in the uterus. By taking it out, you decrease, kind of debulk or decrease the burden of the gestation tissue. And sometimes in patients who we've given them chemotherapy for low-risk disease. So let's say you have a patient, we started on her methotrexate, actinomycin D, or alternated them, and the patient beta HCG is still not normalizing at the right level, and you do a whole workup, and the workup is negative for metastatic disease. Doing a hysterectomy in these patients sometimes result in a cure because you have a resistant focus that is sitting in the uterus, so you are essentially salvaging these patients. I'm going to kind of stop here and thank you.